So you can see this in this cartoon. Looking at the left, you have a relatively normal joint. The white at the ends of the two bones, that's the articular cartilage, the cartilage that lines the bone. As we go to the middle of that slide, you can see that the cartilage is becoming frayed. It's losing its smooth surface. It's losing the ability to move against itself in an unobstructed fashion. And that's what leads to the crepitus, the cracking sensation, the cracking sound. And as time goes on, as the stresses get shifted to the bone grows thicker. You can see that on the right. That's the enlargement of the knuckles that we saw previously on the x-rays and on the photograph. And there's almost no cartilage there anymore. That gray streak in between has been diminished. That's the process. What do we do to try to help people that have this condition? Well, first we have to make an accurate diagnosis, and that's why, again, I come back to when teaching the medical house staff, we have banished the term arthritis. Arthritis is a family of conditions. It's not a disease. We want to make as accurate a diagnosis as possible so that we can treat as accurately and effectively as possible. So, diagnosis of osteoarthritis is based on history, physical examination, x-ray. There are really no laboratory tests that suggest a diagnosis of osteoarthritis. So that's one opportunity we don't have, but the lack of laboratory abnormalities helps us confirm that diagnosis. So between patient telling us what they're complaining of, our examining the patient, or doing x-rays, we can usually establish the diagnosis. Once we establish the diagnosis, we try to teach our patients about the diagnosis, and that's one of the places where the Arthritis Foundation itself can provide wonderful opportunities for our patients. Because they have fantastic resources when it comes to patient education and patient self-help programs, including exercise programs, and I'm sure we will talk more about it as the morning progresses. But the Arthritis Foundation is really a resource that we take advantage of to a tremendous extent as clinicians, and I hope you, if you have the condition or if your loved ones have the condition, take advantage of it too. But with things like exercise, we can improve the function of joints. We can teach people to retrain their muscles so that their endurance and their strength can compensate for what they've lost because of progression of the disease. One of the most important things, we want to keep our patients as upright as possible because many of these conditions lead to difficulty walking and can predispose to falling. And the last thing we want to see is our patients on the ground because when you break things, the consequences are sometimes graver than one would expect or hope. Weight loss, as I mentioned before, very importantly, the more you diminish the stress on the joint, the less quickly the cartilage will deteriorate. And there are lots of other modalities that are helpful, such as varying temperature. Heat will help loosen tight muscles. Cold will help reduce inflammation. They shouldn't be looked at as opposites. They're both useful modalities in many patients. So we establish the diagnosis. We try to teach patients about their disease. We try to get them involved in physical measures to help them. I haven't said anything about medications yet, because medications are probably the least important manner in which we should be treating osteoarthritis. Different than rheumatoid arthritis. And again, that's why I want to emphasize how these conditions differentiate each other, differentiate from each other. There are other things that we can do to protect joints, such as braces, such as canes, such as orthotics. And the purpose of all this is to improve function and decrease pain before we ever prescribe a medication. What can we do as far as medications? Well, there's a lot that we can do as far as medications, although none of them convincingly affect the progression of the disease. So we can prescribe analgesics, and the safest is still acetaminophen, Tylenol. There's been some concern about people overdosing on acetaminophen, and in this past year, the recommendations for the maximum dose of acetaminophen to be taken has been reduced because we became aware that people were taking medications that contained Tylenol or acetaminophen, and they didn't even realize it. So the recommendations now are for people not to exceed 3 grams a day. That's the equivalent of 6 extra strength Tylenol. And as we get older, and as we develop other conditions that might influence the way we metabolize Tylenol, acetaminophen, that amount should decrease. So this is something that you should discuss with your physicians, even though it's available over the counter, even though it's still considered the safest of the analgesic medications. One has to be careful when using Tylenol. There are other over-the-counter medications, NSAIDs, non-steroidal anti-inflammatory drugs. These are drugs that were developed from the knowledge that we have of aspirin. These are aspirin-like medications. They work on the same principle as aspirin to reduce inflammation. They include ibuprofen or Motrin or Advil, naproxen or Aleve, and there's some others that are available over the counter. These are very effective for reducing pain. They distinguish themselves from acetaminophen or Tylenol in that they also reduce inflammation. They have to be used with caution because they have side effects too. They can affect the stomach, they can affect blood pressure, they can affect fluid retention. There's a cardiovascular warning on them now. We have other painkillers, opioid medications based on morphine or codeine. There are some that are less habit-forming than others, for instance, tramadol or Ultram. These can be very effective medications in people who are having persistent pain. I just want to highlight a few things that often come up as questions, and that is the use of topical agents. I mentioned heat and cold to you. There are agents that contain capsaicin, the active ingredient in hot peppers. What makes your tongue burn when you bite into a hot pepper, that has now been isolated and put in gels and creams that you can apply to joints. They can be very effective. They burn when you first put them on. A lot of people give up on them after a day or two because all they perceive is the burning sensation, excuse me, without the benefits. If you keep using it for 4 days, 7 days, 2 weeks, the burning goes away, and many people will get benefits on the pain that they're experiencing. So this is something that is available over the counter, and it's useful for many of the superficial joints, hands, knees. You have to be careful with it. Anything that comes in contact with it will burn. So it's something you have to keep away from your eyes and other delicate parts of the body. There are now aspirin or NSAID-containing gels and creams. They've actually been around for a long time. The first one was Bengay, which was developed in 1899 by a Parisian pharmacist whose last name was Bengay. So that's been around for over 100 years, but now there are some prescription medications, and I've listed them there. They all contain one of the NSAIDs called diclofenac, and they can be very helpful for people that have relatively low-grade inflammation in superficial joints. And there are some other treatments that are approved but haven't caught on, in part because they're not very effective, and that's the last citation there, looking at pulsed electromagnetic field therapy. We can also inject joints, and there are 2 types of medications we use to inject joints. We can inject with cortisone-based medications, and we can inject with a material called hyaluronan or hyaluronate. Cortisone-based medication is very effective for reducing inflammation over the short term. We used to be fearful of them because we thought it may actually accelerate the process, and as it turns out, it probably doesn't accelerate the process, so it's something that can be done repeatedly if necessary, but we don't want to do it too often because some of the medication does get into the bloodstream and it can cause the same sorts of side effects as if you were taking it by mouth. So it can raise your blood sugar, it can raise your blood pressure, it can lead to glaucoma and all the other side effects of cortisone that we worry about. Hyaluronate or hyaluronan, doesn't have any of those systemic side effects. This is a material that's part of joint fluid, part of cartilage. We think by injecting it into the joint, we're actually helping repair the cartilage. So this is a medication that may actually be doing something to help slow the process, to help heal the defect in cartilage. And there's several products that are out there which are approved for administration every 6 months if necessary. There's a lot of unconventional therapies that have been used to treat osteoarthritis, and the most popular ones are chondroitin and glucosamine sulfate. And I have to tell you, the jury is still out on these. There are studies that show they work. There are studies that show they don't work. There's studies that show certain preparations work and other ones don't. And when the literature contradicts itself like that, the bottom line is, if it works, it doesn't work particularly well. You would see more consistent results if these were major interventions. They seem to be safe. So one is probably not harming oneself by using them, but it's unclear how much they're really doing in the way of good. There are other experimental therapies which are very promising. A type of antibiotic called tetracycline has some promising results in the treatment of osteoarthritis, not because of any infection, but because this chemical also has other effects besides killing bugs. And the tetracycline backbone to these medications may have some beneficial effects on cartilage. Bisphosphonates, the Fosamax-like medications, may actually have some benefit on osteoarthritis also, in addition to osteoporosis. We know that massage and acupuncture can help relieve the pain. There are many, many other things that people talk about, some of which may have some science behind them, most of which unfortunately don't. And we can talk about them later in the breakout sessions. And then there's always surgery for the people who don't respond well to the mechanical interventions and the drug therapies. What does the future hold? We can hopefully, in the near future, when I say that in the next 5 to 10 years, take cartilage from our patients, harvest it, grow it in a test tube, give it back to them, and allow the grown cartilage to repopulate the surface of the joints. This is something that is becoming very real.